Chapter 35, HIV/AIDS. So we know that AIDS is an infectious and potentially life-threatening disorder that severely compromises the immune system. And HIV causes AIDS, and people can remain asymptomatic for 10 years or more. And during this asymptomatic time, that they can infect other people. In early history, people believed that HIV and AIDS only occurred among gay men, but that's no longer the case. But we do know that those who are at high risk are gay men, IV drug users, people who are transgender, and prisoners. And so that's 4 things that you need to remember, because that'll most likely be a SATA. So gay men, IV drug users, transgender, and prisoners are at high risk for HIV. Also, if a woman has HIV, she can pass this to her fetus, either in utero through the placenta or through breast milk. So HIV is an altered genetic form of simian, which means monkey, immunodeficiency virus, and it was transferred to humans in Africa, where they consumed meat from chimpanzees. So originally was simian immunodeficiency virus, which only monkeys had, but then humans in Africa consumed meat from infected chimpanzees, which caused HIV. So there's 2 types of HIV. HIV-2, which is the primary type in West Africa. And the difference between this and the other type is that it's less transmittable, and if you have HIV-2, then you can't develop AIDS from it. You cannot. So HIV-2, no AIDS. And HIV-1 subtype B, that's in the United States, mostly the United States, but it's also in the rest of the world. But the distribution of this subtype is changing because of the diverse merging of population. This one is hard to remember, so I'm just going to say it a lot. The fusion of the virus and CD4 co-receptors provide means by which the genetic contents within the capsid, along with reverse transcriptase, protease, and integrase, combine with the genetic code of T4 cell. So, the main thing to remember in that sentence is CD4 co-receptors, they fuse with HIV by the genetic contents that's within the capsid. And also inside the capsid is reverse transcriptase, protease, and integrase, and they combine with genetic code of T cell. So remember, CD4 receptors, capsid, reverse transcriptase, protease, integrase, and T cell. So replication of HIV, how does it replicate? It replicates by altering the helper T cell's genetic code to make more viral particles. And the altered DNA tells the cells how to assemble amino acids to form protein substances such as the virus. And the DNA it provides like a blueprint for making clones of HIV along with the enzymes the virus needs to continue reinfecting additional cells. And let me check something. I think, if I'm right, yes, those enzymes are the reverse transcriptase, protease, and integrase. Those are the enzymes that help the virus reinfect other cells. And then protease, which is the third viral enzyme, what it does, it cuts along the chains, the DNA chains, freeing the replicated viral particles into the cytoplasm of the cell. Some migrate to the cell wall where they form the buds, and then when the buds rupture, they release several copies of the virus, which causes the virus to infect T cells, which that is how it's spread. So there was a man in New York in 2005 who they discovered had 3-DCR, which is a highly virulent HIV, which means that it turns from HIV into AIDS in a matter of months. And it's highly drug resistant, so none of the antiretroviral therapies work well with it. But they also found that he was using methamphetamine, and so they discovered that people who use illicit drugs like methamphetamine can speed up the process of HIV turning into AIDS. So, HIV is not transmitted by casual contact. You can get it through blood, semen, vaginal secretions, and breast milk. And here are some high-risk factors for HIV. So these are the things, if you're doing these things, then you're putting yourself at a high risk for contracting HIV, which is unprotected sex, contact with blood or infectious body fluid, sharing IV needles and syringes, what does that say? Oh. Receiving non-autologous blood before it was screened. So that's like getting a blood transfusion. The blood was not received from yourself or from like a direct donor. And if you received this blood before it was screened for HIV, then you're at risk for contracting HIV. And if you come in contact with infected blood on body piercing, tattoo, or dental equipment. So make sure that you know where you're going is safe and clean to get tattoos, body piercings, and dental work. Also, there's a very high risk that mothers who are HIV positive will give HIV to their fetus. And that can either happen, when they're in utero, or if they become HIV positive after having the baby, then they can still transmit the disease to the fetus/baby through breast milk. So how do you prevent it? Just don't have sex at all. Or don't do anything crazy. Only stick with one partner. And make sure that you use protection that contains non-oxynol 9, which is helps prevent the spread of HIV. Also, don't be using any IV drugs, especially if you're trying to share needles and syringes with someone who could possibly be HIV positive. And then refrain from donating blood if you've engaged in high-risk behavior, then you should refrain from donating blood. Even though they screen for HIV after you've donated the blood, there's still a high possibility that something could go wrong, and you could give somebody HIV by just donating blood. And also, to prevent it, especially with the donation of blood, bank your own blood, which is bank autologous, or directed donor blood, which is from a family member or friend that you know is not HIV positive. So as nurses, we need to always stick with standard precautions, report any needle sticks to your supervisor, because antiretrovirals can decrease the risk of HIV infection if given within 72 hours of becoming in possible contact with it. And since prophylaxis therapy isn't 100%, it's not 100% positive that if you take this medication, then you won't contract HIV, you still need to use protection whenever you are having intercourse, just until HIV is ruled out. So we know that AIDS is the end stage of HIV infection. And how do we know if someone has HIV? It's whenever they have a decreased T4 cell count. When we start noticing going it down below 800 is whenever we'll start monitoring their T4 cell count. And also, if the person started developing certain types of cancer and opportunistic infections that normally they would normally get, something that's not common for someone to get, like obviously a constant UTI isn't going to be something that we're going to assume that they have AIDS with. Like constant, maybe they keep getting pneumonia, or they keep getting the flu, or anything like that. Something that's not common, like a constantly common situation. The pathophysiology of AIDS is, direct contact with somebody who is HIV positive if you've come in contact with their blood and body fluids. Let's see. Then I have here, when HIV infection occurs, T4 cells become infected and they're unable to recognize foreign antigens and simulate B-cell lymphocytes. So we know that T4 cells, they normally help fight infection and keep foreign viruses and stuff out of the body. So once it becomes infected with HIV, they can't recognize these foreign infections and stuff, and they can't stimulate B-cell lymphocytes. And we know lymphocytes also aid in reducing infection. So, infected T4 cells are destroyed by HIV eventually, and B-cell lymphocytes, because the B-cell lymphocytes recognize the T4 cells as being infected, so the body is trying to get rid of those infected cells via B-cell lymphocytes. But even though new T4 cells are being created all the time, the replication of HIV is too fast. So by the time the new T4 cells are being created, HIV is already infecting those. So there's not enough time for the T4 cells to even help with that process. And eventually, the T4 cells are severely depleted, which results in a compromised immune system, and that's when they start getting infections. So, signs and symptoms of AIDS. We know that someone who has AIDS might develop an acute retroviral syndrome, and that looks like the flu. I also have to decide fake flu, chickenpox / shingles, because some of these signs and symptoms aren't really seen with the flu, but it manifests itself as a fever, swollen lymph nodes, pharyngitis, rash around the face, trunk, palms, and soles, muscle and joint pain, headache, and NBD. Also, they might have an enlarged spleen and liver, and there will be weight loss and neurological changes like visual changes and cognitive motor involvement. And going with the cognitive involvement, like cognitive changes, one of the other symptoms of AIDS is AIDS dementia complex, which is after a while they start developing dementia-like symptoms, but they might be as young as 20 and start having issues with their memory and having behaviors of acting out, and eventually get to the point to where they're just not able to take care of themselves, or become like at a childlike state of mind. Also, we may see Kaposi sarcoma, which is lesions on the body. They're purple lesions and they could be painful. And we know that is connective tissue cancer. And they occur all over the body. And then there's pneumocystic pneumonia, and that is seen as a non-productive cough and shortness of breath. Also, with women, they may have an abnormal pap smear test. Genital warts may appear, PID, which is pelvic inflammatory disease, and persistent vaginitis may be some symptoms of AIDS. So how are we going to screen and test for AIDS? So if you're screening, if they have a positive ELISA test, which the ELISA test, it scans for HIV antibodies, then that could be an indicator of being HIV positive. But the ELISA test, they can have false positives. So if they do receive a positive result, then they always do a second test just to make sure that it wasn't just a false test result. Some confirmation, if they receive positive results on these two tests, then there is 1,000% without a doubt means that they have HIV. And those tests are the Western blot test, and that is the main one. And then there's the polymerase with P24. You don't need to know what those mean, just know the names of them. Also, like I said earlier, if they start having a decreased T4 cell below 800, then we're going to start monitoring it. If it's below 500, if their T4 cell count is below 500, then they are considered immunocompromised. And then if it's below 200, then that means they have AIDS. So if it's T4 cell, if below 500, then they're immunocompromised and it's still considered HIV at that point. But if it gets down below 200, then that means that they have AIDS. And we're going to check that count every 2 to 3 months to keep an eye on it, to see, if the medication regimen is working, how fast the disease is progressing, and stuff like that. So medical management, what are the doctors going to do? They're going to prescribe antiretrovirals, which is not a cure. Since HIV and AIDS, there is no cure. So it's just like slows the progression of the disease down. And they're going to use antiretrovirals in conjunction with like antibiotic drug therapy to reduce infection, since they are constantly at risk for any type of infection. So since we're also doing that, critical thinking, they're always on antibiotic therapy. So what are they at risk for? They're in risk for a super infection or, super infection. So HIV, so if someone is positive for HIV, then they will receive pneumococcal vaccines, Hep B vaccines, and the flu vaccine yearly to help prevent those infections. And then drug regimens. Obviously, combination drug therapy is more effective than monotherapy. Normally, with combination drug therapy, they're using 4 or more types at one time. The reason why they do this is because it reduces the viral load and reduces the risk of resistance to the drug. And the goal of antiretroviral drugs is to bring the viral load to an undetectable level. Generally, they are prescribed 2 nucleoside reverse transcriptase inhibitors, and we know that reverse transcriptase inhibitors, reverse transcriptase, that's what makes the body's blueprint, and it interferes with the body's ability to make the blueprint. And an example of a reverse transcriptase inhibitor is the zidovudine, which is also known as AZT or Retrovir, and that is used for prevention of maternal fetus HIV transmission. And whenever we give that to a pregnant mother, we should tell her to look for signs of peripheral neuropathy, because that's a side effect of the medication. And then we know, critical thinking here, if she's at risk for peripheral neuropathy, then she won't be able to feel her feet, her legs, her toes, all of her lower extremities, possible upper extremities, depending on how bad it spreads. So then she's at risk for like a diabetic, getting sores, getting things stuck in her feet, burns, and all of those things is just a breeding ground for bacteria, which causes infection. So protease inhibitors, that is used to treat HIV by blocking the protease enzyme, so new particles cannot mature. And integrase inhibitors blocks the integrase enzyme, and it interferes with the ability to make HIV. So I guess that means it interferes with the ability for HIV to continue to spread to T4 cells. Just with these 3, the reverse transcriptase inhibitors, protease inhibitors, and integrase inhibitors, what they do is in the name. So just remember, reverse transcriptase works with reverse transcriptase. Protease works with protease, and integrase works with integrase. Drug resistance is a big problem with people who are HIV/AIDS positive, because some clients neglect to take their medication, either take it at all, or take it at the same time, or take it with or without food. If they don't take their medication at the same time, say if they don't take it at all, then that's just like antibiotics. Their body will start to build up a resistance to the medication, which means it will no longer work, which puts them at risk for drug-resistant HIV, which is the 3-DCR HIV. And the route of drug delivery is oral, but we need to let them know that oral drug medication could cause GI disturbances, so they need to either try to take it with or without food, whichever one works for them. It doesn't matter. Also, Medicaid is the largest funding, it funds HIV and AIDS care. So, some potential opportunistic infections that a person with HIV AIDS might come in contact with is pneumocystic pneumonia, and that is caused by pneumocystic carni, which they renamed pneumocystic jirovecii. And the reason why they renamed it is because only humans can get pneumocystic pneumonia, so they named it pneumocystic jirovecii. And if someone has this disease, then they may require medical ventilation, whether that be through an endotracheal tube, or depending if it's long-term care, then it might be tracheostomy. Critical thinking with tracheostomy, we're going to do trach care frequently and suction well when doing trach care to reduce occluding the esophagus with like mucus and stuff. And trach care is sterile. Also, with pneumocystic pneumonia, they're going to take prophylaxis medication, which is trimethoprim sulfamethoxole, which is Bactrim. And they're also going to take monthly aerosol pentamide isothianate to help with their breathing. Next is candidiasis, which you know is yeast infection caused by the bacteria Candida albicans. And, that's yeast, which develops in the mouth and in just everywhere, really. It could be vaginal yeast infection, under skin folds in the mouth, anywhere that bacteria can grow, then they are at risk for getting candidiasis there. And we should let them know, and also as nurses, we need to be aware that if we try to mobilize the white plaque that develops, then it may bleed, so we don't need to do that. Also, critical thinking again, candidiasis. If they have oral candidiasis, what are they at risk for? Airway management, so we need to make sure that their airway is still clear. Check their oxygen levels constantly to make sure that they're not losing oxygen due to an increase of the yeast being built up in the throat and the mouth. And with candidiasis, we do frequent and good mouth care, but we don't want to scrub too hard, or we could cause the white plaque to be dislodged and bleed. Then there's cytomegalovirus, which we know is CMV. CMV affects the choroid and retina in the eye, which leads to blindness. That kind of speaks for itself, because that the choroid and the retina is in the eye. So obviously it's going to lead to some visual changes, which is blindness. Also, some signs and symptoms with someone who has CMV, they might experience ulcers, particularly in the esophagus, colitis, diarrhea, pneumonia, and encephalitis. Critical thinking again. With ulcers, you've got increased risk of bleeding, and you've also got acute pain as a nursing diagnosis, colitis, inadequate nutrition due to pain, diarrhea, which can cause dehydration, electrolyte imbalances, pneumonia, we worry about airway management, and encephalitis, we worry about IICP, so we're going to constantly monitor their ICP and cerebral spinal fluid levels, just to make sure that they don't develop encephalitis. If they do have cytomegalovirus, then they're going to be treated with foscarnet, which is also known as Foscavir, and this is going to be aggressive therapy because these symptoms can be severe. Cryptosporidiosis, which is serious diarrhea caused by Cryptosporidium, and that's transmitted by the fecal-oral route, which obviously serious diarrhea leads to dehydration and electrolyte imbalances. Under the basically the Disabilities Act, people who have AIDS, HIV and AIDS, they cannot be fired for their disease, but real world, we know that most job facilities, if they find out that you have HIV or AIDS, which is none of their business to know, you don't have to report that, but if they do find out, they may try to find other reasons to fire you. That way they don't have to deal with discrimination laws. And nutrition for someone who has HIV and AIDS, if they are anorexic, then we're going to tell them, small frequent meals of easily digestible food and liquids when they're not small frequent meals of easily digestible food, and then when they're not hungry, try to do liquids, because they are at risk for diarrhea. Liquids can help with dehydration and electrolytes. Diarrhea and malabsorption may improve when the clients avoid residue, lactose, fat, and caffeine. So we're going to tell them to avoid these types of foods, and it might help them with their diarrhea and malabsorption. We're going to encourage liquids, and if their nutrition is just so bad that they're not even tolerating food, then we're going to recommend tube feeding. And with tube feeding, since it is liquid tube feeding, they're at risk for diarrhea once again, because that's a common side effect. We're going to monitor that closely. And Advera and Impact are commercial formulas that are commonly used for people who have impaired immune systems. So, let's see here. I'm just going to repeat that the fusion of the virus with CD4 co-receptors provide means by which the genetic contents within the capsid, along with reverse transcriptase protease integrase, combine with genetic code of T cell.